So, as Kelly mentioned, it's been a little while since we've had an overview of LAM generally, and so what I've done is I've started the. I'm going to give my basic talk about some of the basic features of LAM, what the disease is, how it affects the lungs and the other parts of the body that are involved by LAM commonly, what the symptoms are, how LAM can progress, and a little bit of new data about the natural history of LAM, and then at the end briefly touch upon what treatments are available. The first sort of thing to say, I guess, is what is LAM? Why does it have this sort of crazy 24-letter name? I have to say, whenever I see a new patient at the LAM Centre, the first thing I do is I say to them, so you've been referred because your doctor thinks you have lymphangiomyomatosis. And as soon as they hear you can say the whole word in one go without forgetting the middle part, they sort of relax that you might know a little bit about it. So the word is just sort of Latin for what people sort of knew about the disease originally when it was described. And so this bit means that it's a disease. It involves the lymphatic system. It involves this angio part of the word it was originally blood vessels, but actually now we really know it's lymphatic vessels that are involved in LAM. And the myo bit in the middle refers to smooth muscle. And the cells that cause the trouble in the lungs and lymphatic system of women with LAM look like smooth muscle cells. So the words are sort of an amalgamation of the pathologic features, really. There's two other bits of terminology that you need to know. You'll often hear people talk about sporadic LAM or TSC LAM. Now, most people that we see at the LAM Centre, or the majority anyway, have something called sporadic LAM, which is LAM that occurs in the absence of any other disease. Just happens on its own. That's a reasonably rare disease. If you have tuberous sclerosis, which is a genetic condition that affects other parts of the body as well, you have a higher risk of having LAM. And LAM occurring in the context of tuberous sclerosis is called TSC LAM. So LAM is a pretty rare disease. The little map here shows the distribution of women with LAM in the UK. The darker areas, they have more cases. It's not that there are some areas that have more than others, it's probably just random detection. When we looked in 7 countries across the world, we found that between about 5 to 9 per million women in a million women, not a million people, so the people at risk had LAM. So it used to be that you were 1 in a million. I'm afraid you're not that special anymore. So there's probably up to 10 times more than 1 in a million. It's almost exclusively a disease of women. Sporadic LAM seems to be exclusively women. Tuberous sclerosis LAM is much more common if you have tuberous sclerosis. If you scan the lungs of women with LAM, you'll see evidence of LAM in about 10% of people at the age of 20, but by the age of 40 years, about 80% of women will have evidence of LAM. The thing about the people with tuberous sclerosis LAM is that most of these people that have a few lung cysts won't get lots of symptoms, although some people with TSC LAM get lots of symptoms. So there are 2 forms. Sporadic LAM is pretty rare. Tuberous sclerosis LAM is still quite rare, but it's common in tuberous sclerosis. So one of the questions that troubles us a lot, really, is why LAM only affects women. And actually, men do get lung cysts, but they don't tend to become ill. So about 10% of men with tuberous sclerosis will have lung cysts, but they don't tend to develop symptoms of LAM. And we think that this is due to the female hormone estrogen. Am I not loud enough? Sorry. So we think that this is due to the female hormone estrogen. And if you get LAM cells in the laboratory and you treat them with estrogen, they grow faster and they tend to spread around the body more quickly when there's more estrogen around. So we think estrogen's probably bad for LAM, and we recommend that women with LAM avoid estrogen-containing medicines like the combined contraceptive pill, hormone replacement therapy after the menopause, and also during pregnancy, people with LAM have more complications on the whole. probably due to the change in hormones, and Steve Hammers is going to talk to that a bit later on. And we also see that after the menopause, LAM doesn't go away, but it tends to slow down a bit. So LAM's an unusual type of disease. LAM's really, at a pathological level, is characterized by a build-up of an abnormal cell type in the lungs and the lymphatic tissue of people who have LAM. The LAM cell, we don't know what the cell of origin is, but as I said earlier, it looks like a smooth muscle cell. And Debbie Clements and Aru Dongre are going to talk a little bit about LAM cells later on, so I'm not going to talk a lot about that now. But LAM cells, unlike normal cells, they don't have the normal checks on growth. Normally, when you have enough of a normal cell type, it stops growing and just does its job in the tissue. LAM cells don't have that break, and they tend to grow abnormally and end up proliferating in places they shouldn't be. And this causes tissue damage in the lungs. This can cause lung cysts, where little bits of the lung become damaged. And these can result in pneumothorax. LAM cells blocking the lymphatics can cause chylous effusions. And this combination of things can lead to breathlessness. So this is a CT scan of a woman with LAM. Most people get told by their physician that they might have LAM after they've had one of these CT scans, and the penny sort of drops. So just to orient yourself, this big sort of oval thing at the top of the picture here is the heart. This is the backbone there. So the front of the patient's right up at the top here, and the back is at the bottom. So we're looking at a cross-section end on. The dark areas, sort of bean-shaped areas, are the lungs here. The grey colour is normal lung tissue. The white things are blood vessels mostly. They're supposed to be there. And the abnormal areas, the things that are the hallmark of LAM, are these cysts, and I've highlighted some of them here. See the round black things, they're areas where the lung has become damaged, and there's actually no lung tissue there in these little cysts. This is somebody with reasonably mild disease who'd have actually fairly normal lung function. But this is the sort of hallmark of someone with LAM. So if we sort of zoom into a sort of pathological level, the slide that's up now is a micrograph of normal lung tissue. So these are the alveolar spaces, and your lung's made up of lots of these spaces, a bit like a sponge, really, and there are little air passages that lead down to these spaces. And if you sort of look in detail, what this cartoon shows you is that the lung's exquisitely arranged to get the air, which is in this bit, in the alveolus, very close to your blood supply. So the capillary and the airspace are right next to each other, so it's very easy for the oxygen to diffuse into the bloodstream and for the waste products, carbon dioxide, to diffuse out. So that's a normal situation. So this is a biopsy of someone with LAM. What you see is some normal alveoli here, but down towards the bottom of the picture, highlighted by this brown staining, which is a stain we've used to highlight the LAM cells, you can see there's these little nodular clumps, and these are LAM cells. And what you can see here is there's a big clump here, and then next to it there's a big space. Now that's not a normal alveolus, that's the beginnings of a cyst. And it's probably because the LAM cells are producing proteins that damage the lungs and cause these cysts to form. And so this is really what makes people breathless. The lungs become damaged and they can't get the oxygen into the bloodstream so easily. So I'm just going to talk a little bit now about LAM-related problems. And the first thing I'm going to sort of highlight is that the picture of LAM has sort of evolved over the years. So this is a pie chart. The slices of the pie show the relative proportion of people coming to medical attention for LAM because of different symptoms. So this possibly beige colour here, I'm a bit colourblind, but anyway, this light-coloured one here, that's people who present with pneumothorax. This blue one, I meant to ask someone before what the colours were. This blue one is people who come to medical attention because of breathlessness. Now, I'm pretty sure these are white and black. So these are other respiratory problems like cough, and the black bit's non-respiratory problems, so problems related to perhaps lymphatic disease in the abdomen. And so if you look at the old literature sort of 10, 20 years ago, what you see is that most of the patients either had breathlessness or pneumothorax, and that led to the diagnosis. And the mean age at presentation was about 35. If you look at a later big registry study done in the US, what you see is that it's still about equal numbers of people coming with breathlessness and pneumothorax, but all these other things, the extra pulmonary problems associated with LAM, are much more commonly leading to a diagnosis, and there are other respiratory diagnoses. And what actually is happening here is that now we do many more CT scans nowadays than we used to. And so what we're seeing is people with milder disease, people with disease in other places, and people presenting with LAM when they're older. In the past, people wouldn't have had a CT scan, people wouldn't have thought about LAM because, oh, well, that happens to people who are younger. But now we're seeing increasingly a slightly different population. And actually, will probably be the population will probably be getting older still if when we look at this again in a few years. So as I said, most people come to medical attention because they have a collapsed lung or possibly breathlessness. So this is a chest x-ray of somebody with a collapsed lung or a pneumothorax, and you can see on this side of the picture the lung's inflated. You can see little lung markings between the ribs. Here, this side of the chest is black, because this is the lung down here, sort of collapsed away. And this occurs when the little cysts leak air out of the lung. Air gets around between the lung and the chest wall, and the lung collapses down. And pneumothorax in LAM can be pretty difficult to treat. I see a few smiles and nods around the place. Often you need recurrent treatments or sometimes surgery to fix these problems. So this is a little cartoon just showing you what's going on. So this sort of equates the x-ray. Here's the heart in the middle. Here's the left lung, and it's on the right of the picture. But the lung's expanded here. And what's happened on this side is that one of the cysts has leaked air out and the lungs to fix that. Pneumothorax probably occurs in about 3/4 of women with LAM at some point. Chylous effusions are where the lymphatic channels, and the lymphatics is a little vessel system that runs in parallel with the blood system, and it drains the fluid away from the tissues. And this sort of usually just works away quietly, not causing any particular problems. When you have LAM, the LAM cells take up residence and grow in the lymphatics. They block the lymphatics, and the fluid that's usually draining quietly through them tends to build up in places. And this can happen in the chest or in the abdomen. And so these LAM cells block the lymphatic flow. And then, again, this little cartoon, what this is supposed to show, this grey area, is lymphatic fluid just around the outside of the lung generally. And this is what it looks like on an x-ray. You can see that the right lung on the left of the picture here is clear, but on the other side you've got this dense area at the bottom, and that's lymphatic fluid. And of course, as that builds up, it squashes the lung a little bit, and allows and causes people to get breathless. In the olden days, we always just used to try and drain these away, or sometimes do operations. Now we have drug treatment that can treat these reasonably effectively. One of the other things that often gets missed with LAM is that the LAM can affect the lymphatics in the abdomen and in the pelvis. About 2/3 of women will have slightly enlarged abdominal lymphatics if you look hard enough, but actually they don't cause any symptoms at all, really. You can just about see them on a scan if you look carefully. What does cause symptoms sometimes are discomfort, or this one might even cause symptoms of urinary frequency. These are fairly unusual, but do occasionally occur and often get misdiagnosed as irritable bowel syndrome, I've noticed. Finally, angiomyolipoma is present in about half of women with LAM. It's a benign growth, usually occurs in the kidneys. This is an angiomyolipoma here, just shown by this arrow. This thing next to it, the white thing, that's the kidney. And this angiomyolipoma isn't very big. It's probably about 2 centimeters across or something. And the majority of these tumours are small. They're present in about half of patients, and they don't really cause any symptoms whatsoever. The problem that we have is that occasionally they can get larger and bleed, and sometimes that's the first thing that alerts you to someone having LAM. They can be easily detected by a CT scan or an MRI scan or even an ultrasound. And so if you have LAM, you really should have your abdomen scanned to see if you've got one of these tumours. You might not need anything doing about it, but you should. They do need following. So the symptoms in LAM are quite variable. The second thing I tell people after I can say lymphangioliomyomatosis in one go is that LAM is an extremely variable disease. And there may be no symptoms at all. And we have people who've had CT scans for completely unrelated reasons, and somebody's seen that they have a small angiomyolipoma and lung cysts, and they've definitely got LAM, but they have no symptoms. The commonest symptom is breathlessness. Nearly everybody has that at some point. People have wheezing. Some people get chest pain from pneumothorax. Cough is quite common, and some people cough up blood. It's part of LAM. Some people cough up the lymphatic fluid, the chyle. Some people are prone to chest infections. And very occasionally, people present with abdominal problems, leading to the diagnosis. Some people get malaise and weight loss, and actually fatigue is probably one of the commonest symptoms in women with LAM, and which isn't really on the radar much. And Sharon Fuller is going to talk about LAM, about fatigue later. Now, a lot of other illnesses can cause exactly the same symptoms, and so one of the reasons that it often takes quite a long time to get diagnosed with LAM is because people attribute breathlessness and wheezing to asthma or cigarette smoking related lung diseases and other problems. So the first question that we often get asked is, do I definitely have LAM? And the European Respiratory Society about 5 years ago set specific criteria to make a firm diagnosis. So if you've got a CT scan that looks like that one, so a typical scan, and then you end up having a lung biopsy and it shows LAM, we can definitely say that you have LAM. If you've got one of the kidney tumours in a CT that looks like that, or a build-up of chylous fluid or abdominal disease from LAM, we can also definitely say you've got LAM, but we don't need to do a lung biopsy. If you have a scan like that in tuberous sclerosis, we can definitely say you've got LAM and we don't have a lung biopsy. There's also a blood test that some of you may have heard of called VEGF-D, and if that's elevated in the context of cystic lung disease, that's also consistent with LAM, although it's quite hard to get VEGF-D tests done in the UK at the moment. If you've just got a scan that looks like that, but you're a woman of about the right age and things seem to fit, you've probably got LAM, and sometimes we don't actually do a lung biopsy to confirm that, but if we want to know for sure, very often we have to do a lung biopsy. If you've got a CT scan that shows lots of holes, but it doesn't look completely like LAM, then we call that possible LAM. Now this CT scan, as you can see, there's quite a lot of holes in the lung, but actually this person has Langerhans cell histiocytosis, which is another cystic lung disease. And if at first glance the two scans look fairly similar, so sometimes we do need to do biopsies to differentiate between different lung diseases. So once you've been told that you have LAM, sort of what's going to happen after that? Well, as time passes, most women with LAM, although not everybody, and as I said, it's a very variable disease, tend to lose lung function at a gradual rate. This is data from the LAM Centre where I work, And what this shows, each one of these lines is a patient's lung function. And everybody who comes has their lung function plotted, and we work out how quickly it's changing year on year. And what you see with these lines on this side, now these are patients who aren't being treated with rapamycin, the mTOR inhibitor, the new drug. And you see, if you take on average, this is the average value of change here, and so they're losing FEV1 at about minus 70 mils a year. Now, a person with no lung disease is FEV1 as they get older, and changes by about 20 to 30 mils a year anyway. So people with LAM are losing lung function faster. Although that's obviously not great, when we looked in the old days, when I sort of started getting into LAM when I was working for Anne, we did a study like this, and actually the change was 120 mils per year. And so something looks like it's probably changed for better, mils per year. So if people are this one walks slower on the flat, this is too breathless to leave the house, and so on. So what this graph shows is 10 years from developing your first symptom of LAM, about half of patients will be breathless on LAM when everybody was told that they had between 5 and 10 years from diagnosis. Actually, 10 years, over 90% of people are alive, and the median survival now is approaching 30 years all out in the latest studies. So how should we monitor people with LAM? And most of you know this because it's probably happening. So most get them once a year for a bit of an MOT. So we monitor lung function each time. If you've got kidney scans, we also if you've got kidney angiomyolipomas, we also scan the kidneys to see if the angiomyolipomas are growing. This 30 millimeters, and some of them actually get quite large, so that big to maybe that big. These are much more likely to grow quickly. So if you have may improve lung function slightly in LAM, and so these can make angiomyolipomas small, and that's an effective treatment for people with progressive disease. I'll show you a few more details on that. There are a number of other drugs that you may have heard of on the internet that are being tested for LAM, and Debbie Clements is going to talk a little bit about these later. But there are a few promising things on the horizon that you might add into rapamycin, or in the study we tested to see if doxycycline was helpful a few years ago for LAM, but actually there was no evidence that was effective, so we don't use that now. So I'm just going to show you a little bit about the MILES trial, which some of you may have seen before. So the MILES trial was the study that showed that center, as we often measure people's oxygen saturations over a 24-hour period to see what they need, how often their oxygen falls, treat them early. You need to talk to your doctor before getting treatment, just so you can plan in advance. It helps to keep active, and there are rehab programs for people who get breathless when they exert themselves called pulmonary rehab. And most women with LAM who have breathlessness on exertion will probably benefit from pulmonary rehab. So what not to do: don't take things with estrogen in, don't smoke cigarettes, fairly obvious really. And the other main do's and don'ts are not to let chest infections drag on. So the sort of advice for most people if they get a respiratory infection is to stay at home, don't need antibiotics, it'll go away. If you have a lung disease, then it's usually appropriate to take antibiotics earlier. So you probably want to go and talk to your doctor if you get symptoms of infection. You do need the appropriate eventualities. So that's all I've got to say, really. I'll just say thank you to people who have funded our research and the team at the LAM Centre. And just a quick plug, we've been funded recently to do a biomarker study, which is a study which allows us to, which hopefully will allow us to identify proteins in the blood to predict how active LAM is. So we could target treatments to the people at risk and leave the people who are going to stay stable for a long time to their own devices, safe in the knowledge that they're unlikely to come to harm. So this is called the BioLAM study. It's running through the LAM Centre in Nottingham and will be in a few other places around the country when it's set up in the next few months, and really just involves a blood sample a couple of times a year. So do consider taking part in that. I think Helen Jones, our new research nurse, is going to be around over lunch. So if you see Helen, she'd be happy to chat to you about the study. I'm going to take questions during either the question and answer session, or come and grab me over lunch or something, as we don't have time for them now. But thanks very much.